Good afternoon to everyone. The Philippine Standard Time is 2 o'clock in the afternoon. Welcome to the second day of this webinar slash virtual workshop series entitled Introduction to Evidence-Informed Policymaking for Health. This is the second day of the webinar for which we had the first day last Monday, and the virtual workshop was actually started yesterday for our workshop participants. This is Dr. Dennis Bibatangan from the Ateneo de Manila University Institute of Philippine Culture. Before we start, we'd like to inform our participants that this webinar is being recorded and you may access the replay on the DOST-PCHRD YouTube page by next week. So for this afternoon, the program will be as follows. Next slide, please. It will start with the house rules, by Ms. Julian Garcia, followed by the lecture of Dr. Harvy Joy Liwanag on evidence-based informed policymaking in time of COVID-19 pandemic, selected case studies. And then after Dr. Liwanag's lecture, there will be an open forum, which will be moderated by yours truly. And then it will be followed by the lecture by Dr. Jason Ligot, who I will introduce more extensively later. When we will have a break, no? So during the lecture of Dr. Ligot, there's going to be a 10-minute break.
Ano na?
For which
Oo, sa
we
YouTube.
would like to ask everybody
Ito
to
kasi
stay on,
webinar jam eh.
to stay on, during that particular break, and then we'll continue on and then proceed to the continuation of the lecture of Dr. Ligot, and we'll have the open forum. And then after that, Dr. Harvy Liwanag will be with us again to give instructions, and reading assignments and mechanics for the group work, because there's a group actually within the participants attending this webinar who are actually participating in virtual workshops. So with that, I'd like to turn over the floor to Ms. Julian Garcia, who is a senior science research specialist and also the head of the Research to Policy Translation Unit of the Department of Science and Technology, Philippine Council for Health Research and Development. So, Yuli, over to you.
So good afternoon. So these are our house rules. During the webinar, if you encounter connection problems during the webinar, please click the reconnect button. Participants are in listen-only mode. You may ask questions or comment through the chat box on the lower right corner of the screen. Please make sure to type in your name and institution with your questions or comments. Polls will be conducted from time to time. To answer a poll, hover over the poll icon to select your response. During the open forum, the moderator will read and direct the questions to the resource persons. We always value respect and courtesy during the entire webinar. This webinar is being recorded. Next slide, please. So after the webinar, the organizers will send webinar codes at the end of each day and the link to the webinar evaluation form on the last day, that's on Friday, via email. Certificates, announcements on webinar replay, and webinar presentation links will be automatically sent to your emails at least 72 hours or 3 working days after filling out the evaluation forms. Please double-check your email address during your registration and when answering the evaluation. You may not receive your certificates if your email address is incorrect. Also, please check your spam folder. Next slide, please. Other webinar reminders. Certificates of attendance will be given if all 3 days are attended and if the attendee answers the evaluation form, which is emailed after the last activity on Friday. Certificates of participation will be given to the virtual workshop participants who will be doing additional work. Please note that attendance to webinar replays does not qualify for issuance of certificates. So for any administrative questions, don't hesitate to contact the DOST-PCHRD Research to Policy Translation Unit at these emails. Thank you.
Thank you very much, Ms. Julian Garcia, no, for giving us those house rules and some reminders. As we said, no, this is the second day, no, of this webinar series, and we're very fortunate again to have Dr. Harvy Liwanag as our main resource person for this particular lecture. No, I'll briefly introduce Dr. Liwanag again because we have additional participants from the original set of participants we had last Monday. As of this, before we started, the number of pre-registered participants increased to 1,800. And as of now, we have around 860 participants with that. So we hope the other pre-registered participants can still join the session this afternoon. So Dr. Liwanag is a medical doctor and a health system specialist. Through the Balik Scientist program of the Department of Science and Technology, he returned to the Philippines in 2019 and joined the Department of Health, specifically the Health Human Resource Development Bureau of the DOH, where he provides technical assistance in strengthening the health workforce as a critical component of the health system. Dr. Liwanag has a number of publications that analyze health system governance and decentralization. For the current pandemic, he is assisting the DOH in forecasting the number of health workforce required in the Philippines in order to address the rising cases of COVID-19 adequately. Between 2015 and 2019, he was with the Swiss Tropical and Public Health Institute in Basel, Switzerland for his PhD in epidemiology, which was funded by the Swiss government. He was a former researcher at the University of the Philippines, National Institutes of Health, between 2012 and 2014. He obtained his MD and MBA degrees, that's a dual degree, as a member of the pioneering batch of graduates of the Ateneo, the Manila University of School of Medicine and Public Health in 2012. So with that introduction, and hopefully most of our participants are already settled now to listen to the next lecture of Dr. Harvy Liwanag, which will be on the topic evidence-informed policymaking in the time of COVID-19, at the time of COVID-19 pandemic, selected case studies. So with that, over to you, Dr. Harvy Liwanag.
Thank you so much, Dr. Dennis Batangan, for the kind introduction. And it's nice to see you again and to collaborate with our partners from eTURO and ADM UIPC for this webinar series. So good afternoon, ladies and gentlemen, mga minamahal naming kababayan. I'm happy to be back today to speak to all of you again as part of this first DOST-PCHRD virtual workshop webinar on evidence-informed policymaking for health, which we especially conceptualize for early career researchers. And we are very happy to have received positive feedback from you during our last session last Monday. And I can see that as I speak now, we are being joined by about 896 participants who I believe are tuning in from various parts of the country. So thank you so much for spending your time with us this afternoon and for your interest. Today, I will talk again about evidence-informed policymaking for health, but I modified the title of my presentation because I realized I will not be talking only about COVID-19, but really more on a review of some of the study designs. And we will also explore research translation into policy by looking at selected cases or examples. Next, please. So this is our goal and learning objective. So our main goal for this lecture is for you, our participants, to appreciate how research evidence helps to inform policy development or program implementation in public health. Next. And our specific objectives are as follows. So I hope that you will be able to compare study designs and understand how the strength of their evidence may enhance health policy or programs. And secondly, we hope that you will be able to analyze selected case studies as examples of how research can contribute to health policy or program analysis and action. Next. Okay, what is this? It's a photograph of a group of people somewhere in the Swiss Alps. And the photo appears pixelated. So it's a low resolution photo. Next. And that's because, in fact, the real size of this photo is this one. It's pixelated because we stretch it so much beyond its actual size. Next. But when we are given the opportunity to see the whole picture, we get a better appreciation of the scene. So it's not just the group of Europeans in the Swiss Alps. This is actually at the peak of Jungfraujoch in Switzerland. Those of you who watched Crash Landing on You, this was one of the scenes where Captain Rhee and his fiancée, so they were visiting this site in one of the episodes. Okay, next slide. So I'd like to use those photos, as somewhat as an analogy of what I'd like to point out when we try to understand the hierarchy of evidence in health research. This is a figure I borrow from Yetli et al. And I'm quite sure that some of you have seen this or a similar version of this before. And by the way, this pyramid is not encompassing of all study designs out there which are relevant to health research, because there are many other study designs, but I am just simplifying it in this way for the sake of discussion. So at the bottom of the hierarchy, we see here editorials, expert opinion. We go up the hierarchy, we see case reports, case studies. Further up the hierarchy, we see cross-sectional studies, surveys, and then we see case control studies, cohort studies, and then randomized controlled trials. And at the top of the pyramid, we see systematic reviews and meta-analyses of randomized controlled trials or RCTs. Now, we might think of systematic reviews and meta-analyses as somewhat like the big painting, okay? Or the big picture rather that you saw earlier, the photo of the Swiss Alps, because they draw from the results of several studies that have been done and thus provide us with a synthesis of the research. Whereas the other study designs below the hierarchy, as often these are individual studies, we may think of them like that small picture of the group of people, okay, which is only part of the bigger picture. And if you force to expand the picture beyond what they actually are, what you get is a pixelated picture. You cannot interpret the results of the studies at the lower part of the hierarchy beyond what the nature of their study design could offer. Next. And so the study designs at the upper part of this pyramid, next, since they are considered more rigorous, they are viewed to have a lower risk of bias. On the other hand, the study designs at the lower part of the pyramid are considered to have a higher risk of bias. Next. That's also because the study designs at the upper part of the pyramid are designed in such a way the results are generated in a more objective way, whereas the study designs at the lower part of the pyramid are viewed to generate results that are more subjective. Next. And so when we consider the quality of the evidence, that as you go up the pyramid, you consider the quality of the evidence as higher, and as you go down the pyramid, you consider the quality of the evidence as lower. Next. Now, this is a question. Is it correct then to say that the study designs at the upper part of the hierarchy are therefore more useful for policy, whereas those at the lower part of the hierarchy are less useful for policy? Next. This is a question I am posing, and we have researchers who, especially in health research, who also think this way. And sometimes they are more exposed to the quantitative approach in health research. Next. However, I would dare say that this assumption is not entirely correct and not helpful if we want to strengthen evidence-informed policymaking for health. Because first of all, it really depends on what the policy question is. And hopefully at the end of this lecture, we will be all in agreement on why we should not be thinking in this way. Next slide. All right, so let's then quickly review, because I think many of you already know these designs now, but let's quickly review some of these study designs. Let's start from the bottom of the pyramid. So what is a case report? Well, if you have an interesting and rare case that has rarely been studied in the past, and by reporting about it, you contribute new understanding about this topic, that is a case report. Like for instance, this is a case report of a patient with SARS and who is also pregnant. So it's an interesting case and you write a case report about it. And then if you have multiples of those cases, allowing you then to describe their common characteristics, then you can have a case series like this one. A case series of 138 patients in Wuhan way back in February, which was one of the first to describe the clinical characteristics of COVID-19. And at that time, it was not even yet called COVID-19, but we tentatively called it the virus as 2019 nCoV. So, what are the strengths of case reports and case series? Well, one of the strengths is that they can provide inexpensive, detailed assessments. They can be useful for evaluation of rare diseases. We can use them to identify rare events. On the other hand, what are their weaknesses? Well, it's difficult to draw definite conclusions because in this case, we do not have a comparison group. The other limitation is that there is also a high risk for selection bias. So for example, if patients who recover very fast, or on the other hand, if they die right away, they may be underrepresented in a case series. So does that mean that these studies have no effect on policy and practice? Not necessarily, because they often describe a new disease we still don't understand. The first description of such a disease through a case report or a case series will help us begin to understand the disease, how to diagnose it, what are the clinical manifestations, what may be the initial options for treatment, what are the initial trends when it comes to prognosis. And this is actually how we started our understanding of COVID-19. Next. What about a cross-sectional study? Here, let me share a publication on a research undertaking I had with Dr. Vicente Belisario, currently the Dean of the UP College of Public Health. In this paper, we described the parasitological, particularly soil-transmitted helminth infections, and the nutritional status of preschool-aged children in 4 villages in southern Leyte. And the graph here shows you that one barangay has a prevalence of soil-transmitted helminth infections at almost 70%. And we were interested in the relationship between the implementation of community-led total sanitation in these barangays and the prevalence of parasitic infections. And so what's a cross-sectional study? It's a snapshot of exposure and outcome. What are the strengths? Well, these studies can help us generate some hypotheses of the relationship, and they can be relatively conducted rapidly. What's the weakness? Well, in this case, we cannot really attribute causation. Uh, for this particular paper, we were not able to prove whether the high prevalence of infection in this barangay was caused in any way by the sanitation status of that barangay, because this is only a snapshot. It's only a one point in time. We don't have data before and after. Neither do we have data for a control group for a comparison. But does that mean that this particular study doesn't have an impact on policy? Obviously not, because the first thing that is very clear here is that we have to intervene right away and first treat those barangays with a high prevalence of soil-transmitted helminth infections. That in itself is research translation, and it provides an opportunity for us to re-examine the program on sanitation that is being implemented in these barangays. Next. Again, I will emphasize cross-sectional studies cannot prove causation. This is a funny article published in the New England Journal of Medicine, describing the relationship between kilograms of chocolate consumption per year per capita and the number of Nobel laureates per 10 million population. Obviously, my other favorite country, Switzerland, is up there. Does this mean that by eating more Swiss chocolates, you become more intelligent and you have the potential to win a Nobel Prize someday? Of course not. You have a higher chance of getting diabetes instead. The relationship here is just association. Next, please. And association is not necessarily causation. Okay? On the other hand, we may expect the reverse to be true, that if there is causation, there is likely an association between the two variables. Next. This is a case control study. Okay, so a case control study is also an observational study, like our cross-sectional study. Observational because we are just observing and not intervening. In this case, we have two groups with different outcomes of interest. Your cases have the outcome of interest. For example, they have the disease, and your controls don't. And then we match the two groups, and then we go back to their history of exposure, and then we compare if they have any difference in their extent of exposure. And we will know the difference by calculating. And for case control study, what is the calculation? It's an odds ratio. The odds ratio will tell us if there is any difference. No? So it's also very useful, this particular study design, for quite uncommon conditions, because we start by identifying the case. Okay. One classic example of the utility of case control study designs is this paper in the New England Journal of Medicine, published in 1971. At that time, there was a cluster of young women, ages 15 to 22, who were diagnosed with vaginal cancer. Very unusual for this age group, and also very rare. And so with the case control study design, they were able to identify the exposure as diethylstilbestrol, or DES, which in the 1940s was being prescribed to women having difficult pregnancies, not knowing that in utero exposure of the fetus to DES results in vaginal cancer 15 to 20 years later. So causation was possible here, unlike in a cross-sectional study design. But what are the strengths? Well, for a case control, this is useful for studying rare outcomes. It can be conducted at low cost, especially when what we need to do is simply records review, and we just have to look at the data. And so we can also complete it rapidly. What would be the weaknesses of this design? Again, there's a selection bias here. And we cannot obtain the rate of the disease in the population because we are counting the cases. Does that mean that this particular study design doesn't have any policy implications? Of course not, because certainly we identify the exposure, and that can guide us in formulating preventive measures. Next. This is a cohort study design. So here we have a longitudinal study. You have two groups, one with the exposure, the other without. And then we follow them up until the outcome of interest appears. Usually the approach here is prospective, but it's also possible to do it retrospectively. And then we compare the two and see how different they are by calculating the risk ratio. So a classic example of a cohort study is the Framingham Heart Study, which began with a cohort of participants from Framingham, Massachusetts in the US. And by the way, it's still ongoing. By now, over 3,000 papers have been published using the Framingham data, and they have contributed a lot to our understanding of the risk factors for cardiovascular diseases. What are the strengths of cohort studies? Well, we get to establish a clear temporal relationship between exposure and outcome because we start with the exposure and then we follow up the participants. We can evaluate a range of outcomes, okay? And we may also focus on rare exposures. What are the weaknesses of this study design? Well, this is not very efficient if you have a very rare disease because you have a less chance for that disease to emerge as you wait. This study is also time consuming and expensive because we have to wait, usually for many years. There's potential for loss to follow up because some participants might discontinue their participation in the study. Does that mean it doesn't have any policy implications? Of course not. Cohort studies have been very useful in developing preventive measures because we now know that the risk factors that are associated not only with cardiovascular diseases but also other diseases such as certain cancers. Next. Now we're going now to somewhere near the top of the pyramid. So this is our randomized controlled trials. Why are they considered very high quality? So this time we just don't observe. Okay, the previous designs, they were classified as observational, but this time we are intervening. We are doing an experiment. We have two groups, an experimental and a control group, and we allocate randomly to minimize the bias on who gets to which group. And for the test group or the experimental group, we give the intervention. For the control group, we give nothing or we give a placebo. And then the outcomes emerge. And because the two groups have been randomized and almost similar in characteristics, except for the presence of the intervention, then we can say for certain that the outcome was indeed caused by the intervention. So we use RCTs if we like to test the effectiveness of drugs or vaccines, or in this case, like the many RCTs now being performed for the potential COVID-19 vaccine. What are the strengths of RCTs? Certainly we can demonstrate causal relationships. We reduce bias and confounding. We are able to demonstrate effectiveness. What are the weaknesses? Well, first of all, it's very resource intensive, so you need budget and you also need time. And there are also limitations which I will mention later. This is also not practical if you have urgent concerns. But for example, this time when we have an extraordinary pandemic, the regulatory procedures are accelerated so that we can do the RCTs for the vaccines. So, okay, so usually the RCTs are for testing new drugs and vaccines, for example, and other health technologies. And obviously, what are the policy implications for that? So we have a new product that can treat humanity, okay, and that can contribute to making populations healthy. Next. But I'd like to say that RCTs are not only for drugs and other health technologies. We can do community RCTs to evaluate the effectiveness of programs. For example, the conditional cash transfer program that we have in the Philippines. So this was an RCT that was done by the DSWD with the World Bank in 2012. We all know that our government has poured a substantial amount of money to the CCT, or the Pantawid Pamilyang Pilipino Program, or 4Ps. Under this program, poor households receive cash transfers from the government, but it is conditional. The parents have to keep their children in school, and they have to keep their children healthy. So in this study, they did an RCT to assess if 4Ps was indeed effective in achieving those goals for the kids. The RCT compared areas with 4Ps as the treatment group versus areas without 4Ps as the control group. The study was able to show a significantly higher school attendance rate among 4Ps versus those who are not 4Ps. And that's true in three age groups, more pronounced among 15 to 17 years old. Next slide. In fact, last year, the three people who received the Nobel Prize in Economics, Esther Dulfo and Abhijit Banerjee of MIT and Michael Kremer of Harvard, they were recognized for their work in RCTs, in showing how effective poverty alleviating programs are through the use of RCTs. For instance, they did an experiment before in Kenya, looking at Kenyan school children in the mid-1990s. And they found out that just giving them extra textbooks did not really improve student outcomes, suggesting that a simple lack of resources was not the main impediment to learning. Next slide. But of course, while many people are fans of RCTs, and they consider RCTs like the best study design out there, well, we also have people who think that sometimes there is too much an emphasis on RCTs. This is Dr. Tom Frieden, former director of the US CDC. What did he say in this article, which I recommend that you look into, and it's probably free, from the New England Journal of Medicine. There he wrote, a core principle of good public health practice is to base all policy decisions on the highest quality of scientific data. Although randomized controlled trials have long been presumed to be the ideal source for data on the effects of treatment, other methods of obtaining evidence for decisive action are receiving increased interest, prompting new approaches to leverage the strengths and overcome the limitations of different data sources. What would be the weaknesses of RCTs? Well, in an RCT, we have a very controlled environment. So we assign which goes to the experimental and which goes to the control group. So sometimes the potential for validity is limited to the study, to that particular study population, with limitations in relevance to actual and realistic conditions. And RCTs usually are experiments that apply an intervention only to a randomly selected portion of the targeted population. So you cannot really compare the effects of that intervention against a group that did not receive it. Usually RCTs focus largely on usually RCTs focus on smaller problems, rather than trying to answer large nation-scale problems. So next, at this point, I'd like us to do a poll. So please hover your poll icon, and for the next 30 seconds, may I please ask you to vote. Okay, this is the question. Is the TB program strategy called DOTS, Directly Observed Therapy Short Course, effective in achieving better treatment outcomes among TB patients? Yes, no, it depends, we don't know. So please, for 30 seconds, kindly vote. Okay, there's a battle between yes and it depends, but yes is leading the way. All right, shall we close in 5 seconds? 5, 4, 3, 2, 1. Shall we end the poll? And can I ask our team to please flash the results? Okay, majority of you said yes, 56%, followed by it depends. Okay, and the rest answered we don't know and no. Next slide, please. I guess we're all familiar with TB dots. So it's an official program here globally and also in the Philippines. So in this case, TB patients are directly observed by the health worker in the community as they take their TB drugs. Okay, next slide. So we were talking about RCTs, and we said that RCTs can be very good when it comes to demonstrating effectiveness. So there was one RCT conducted regarding TB dots, published in no less than The Lancet way back in 1998. So in this study, they did an unblinded randomized controlled trial in two communities with large TB caseloads, and they included 216 adults. Okay, what were their findings? And I'm going to read it as shown on the screen. Treatment for tuberculosis was more successful among self-supervised patients, 60% of patients, than among those on directly observed, or 54% of patients. So there is a difference of 6%. And they conclude self-supervision achieved better outcomes for red treatment patients. Supportive patient-care relations rather than the authoritarian surveillance implicit in direct observation may improve treatment outcomes and help to control tuberculosis. So what are your thoughts on this? Does this RCT mean that if there is no better outcome among patients being treated by DOTS, let us then just dismantle the program? Let's not do DOTS anymore. Let's just do self-supervision, as this study has recommended. Next slide, please. That was an RCT, but we also have many other studies, not necessarily an RCT, but in this particular one, we have a case control study. And in this case, they looked at TV patients, and then the case control, you start with the case and then you go back to exposure. And I tried to go back and looked if those patients had selective dots or they had universal dots. So it's not really a comparison between dots and no dots. No, it's selective dots directly observed and universal directly observed. What were the findings? Well, I read the results now as flashed on the screen. Isolates belonging to resistant cluster remain significantly more common in the selective directly observed treatment county versus the universal directly observed treatment county. So by the way, they compared counties. This was in Texas in the United States. So what are their conclusions? The data suggests that resistance is less likely to develop and be transmitted when persons with tuberculosis are managed within universal directly observed treatment as compared to selective directly observed treatment. This is not an RCT, but it suggests a totally different finding compared to the RCT in the Lancet. So what is our decision if we are the policymaker? Do we continue with DOTS, or do we terminate DOTS and just do self-medication for our TB patients? I'm not going to answer the question, but these are things that would be nice to discuss, no, and think of. Next slide. We haven't talked about systematic reviews, okay? But systematic reviews and meta-analysis, these are the study designs at the peak of the pyramid. And we know what systematic reviews are. So we look at the literature. Well, first we define the research question. Then we look at the literature, search for studies, and using a criteria, select the studies, extract the data, synthesize the data, and then we interpret the results. Now, if you are able to do a statistical analysis, especially if you have less heterogeneous papers included in your systematic review, and you can actually compare the statistics, then you can do a meta-analysis. And this is the forest plot for a meta-analysis. And by looking at the forest plot, you will be able to see which studies are showing that the treatment is being favored versus the studies that are showing that the results are favoring the control. So you're familiar with this, I'm sure. Next slide. And I'm sure you're also familiar with the Cochrane Collaboration, which is a collaboration of systematic reviewers, and they are organized into different groups. And when a systematic review is published in the Cochrane Collaboration, it's often a very rigorously done systematic review, and we often, of course, believe what it says because it's being published by the Cochrane. Next. Shall we do another poll? Okay, so let's talk about deworming now. Is the program on mass deworming of school children for soil-transmitted helminthiasis effective in improving children's height and school performance? Yes, no, it depends, we don't know. Okay, let's open the poll, please. Okay, please vote for the next 30 seconds. Oh, okay. Yes is leading by 60%, 60, 50. Mahabol no, mahabol it depends. But still, yes, leading by 50%. Okay, shall we end in 5 seconds? 5, 4, 3, 2, 1. Let's end the poll. Okay, so half of you said yes, followed by it depends, and then no, and then we don't know. Okay, next slide. I think everyone is familiar with this, no? We have mass deworming. This is a global strategy. It's not just for the Philippines. And in the Philippines, we do it twice a year. So it's school-based. We deworm our school children. And the idea is that when you deworm, because of the high prevalence of soil-transmitted helminth infections among school-age children, when we deworm, we don't only treat the soil-transmitted helminth infection, but that should also contribute to better nutritional status, lessen the anemia, the prevalence of anemia, and improve school performance. Okay, next slide. So there was a Cochrane review on deworming. The first one, this was in 2015 yata ito. Okay, and then there was an update of that review just last year, 2019. This was done by David Taylor Robinson, and I had the chance to meet him when this study was being debated, okay, some years ago. So what did the Cochrane review say? Regarding the regular treatment of public health programs with antihelminthic drugs for children in endemic areas, there is quite considerable evidence that there are no benefits in terms of hemoglobin, cognition, school performance, and mortality. Per weight, contemporary studies show no effect. Deworm tayo ng deworm, wala namang palang benefit when it comes to improving anemia or school performance or improving weight, for example. Sabi ni Cochrane, what do we do now? Do we terminate the program and stop mass deworming? WHO hasn't said anything, so it's still an official strategy to do mass drug administration. Next slide. But then, of course, the reviewers also say it is good medical practice that children known to be infected with worms should receive treatment. This is obvious and not the subject of this Cochrane review. And then furthermore, they say, we suggest that the current evidence does not support large public health programs of deworming in low and middle income countries. Next slide. And so further studies, that's what they're suggesting. Further trials, in fact, no? So RCTs na naman, may be justified to evaluate whether subgroups of children in populations stand to benefit from deworming, since it is theoretically possible that deworming could benefit a small number of children that are heavily infected whose weight gain is diluted to become undetectable in population-level studies. Next slide. Matagal pinagbatihan itong study na to kasi, you know, it's an official policy or program at national level, global level. WHO has it as a strategy. Many NGOs are endorsing mass deworming. The Bill and Melinda Gates, for example, is spending money to finance deworming in many low and middle income countries. So there was a phase that was called worm wars. Okay. But still, the program is there. So what I'm saying is that even with the Cochrane review saying otherwise, it hasn't really changed the policy, okay, despite what the review has said. Okay, next slide. Okay, let's do another poll. Does the policy that require people, or this is COVID related now, to go on quarantine if they traveled from a country with an outbreak of COVID-19 help in reducing transmission? Please vote. Yes, no, it depends. We don't know. Please start the poll. So pag galing ka sa ibang bansa na may COVID and pabalik ka ng Pilipinas, for example, should you quarantine yourself? And is that effective in reducing transmission? Okay, I'm a bit late, so okay, we will end the poll now. So we see, shall we end it? Okay, now, majority said 85. Okay, 85% said yes. Okay, and then malayo naman na yung ibang answers. Okay, next slide, please. So we know that. So Filipinos arriving in the country need to quarantine. Even other countries are implementing it, like New York, for example, if you came from another state. Next slide. Ito na naman si Cochrane. Okay, let's go back to Cochrane. In fact, they did a review, but this was a rapid review given the urgency of the situation. So they looked at the literature. If quarantine alone or in combination with other public health measures actually is effective in controlling COVID-19. So in this case, they were able to include 29 studies. 10 were modeling studies, 4 were observational studies, and 15 were modeling studies. So wala pang RCTs kasi bago pa lang, no? And what is the conclusion? Current evidence from COVID is limited to modeling studies, and that makes parameter assumptions based on current knowledge, based on current and fragmented knowledge. The results consistently indicate that quarantine is important in reducing the incidence and mortality during the COVID-19 pandemic. But, this is the important note, applying quarantine early and combining quarantine with other public health measures is important to ensure effectiveness. So it's not just quarantine alone, but has to go with other public health measures for it to be effective in controlling the transmission of COVID-19. Next slide. Okay, another poll. The policy that requires the public to wear masks, is this effective in reducing transmission of COVID? This is for COVID in particular. Yes, no, it depends, we don't know. Shall we open the poll? Wearing masks to prevent COVID transmission. Okay, we'll end in 5 seconds. 5, 4, 3, 2, 1. Okay, as expected, majority voted yes, 89%. Okay, next slide. But you know, the WHO was not recommending wearing of masks previously. As you see there, WHO stands by recommendation that you don't need to wear a mask if you're not sick, and if you're not caring for someone who is sick. But then recently, WHO changed the recommendation. WHO now recommends that the public, okay, not just the health workers, but the public now wear masks to prevent transmission of COVID. Next slide. This was the recommendation. You can look into it in the WHO website. But again, it was based on a systematic review, okay, with a meta-analysis from the Lancet this time. And what did they conclude from that study? They searched the literature and they identified 172 observational studies, observational studies, not RCTs, across 16 countries and 6 continents. So no randomized controlled trials. And they conclude that face mask use could result in a large reduction in the risk of infection. Next slide. So WHO changed its stance. So Director Tedros of the WHO gave this statement last month. I wish to be very clear that the guidance we are publishing today is an update of what we have been saying for months, that masks should only ever be used as part of a comprehensive strategy in the fight against COVID. Masks on their own will not protect you from COVID-19. Next. So far, we've been exploring questions that try to see effectiveness. Is this program effective or not? Is this policy effective or not? But those are not the only questions that are being asked in the world of policy. Next. There are also questions like this. So you ask what? Okay, for example, what is the experience of patients with this new program? So this is not an effectiveness question. You want to know something about the program. What is the experience of health workers in a training program, etc. And these questions are also relevant, okay? And the answers, the researches that will answer these questions will also have policy implications. Next. And for me, sometimes the more important questions are the whys, okay? Why is program X more effective than program Y? Why do health workers act unexpectedly when implementing the program? So this is also a different set of questions when it comes to policy. Next. And for me, to answer the why, this is where we need qualitative research. And I think many of you are familiar with qualitative research. So in qualitative research, we have a systematic approach to health, illness, and healthcare, which aims at generating a comprehensive description, analysis, and interpretation of complex processes, relations, and settings, and deep insights into the perspectives and experiences of study participants. Next slide. Many are familiar with quantitative, and we know that quantitative research gives us numbers. It gives us a number for prevalence or for an odds ratio or risk ratio. In Quali, we don't get numbers. We get text, for example, when we interview people, and we analyze the text with thematic analysis. And this is how we can explore further and answer the questions on why. So they are different, okay? But for me, next slide. It's usually better if we combine the two because there are questions which quantitative research will not be able to answer. And those questions can be answered by qualitative research. So personally, my favorite study design is actually a mixed methods study design. Next slide. So for example, I'm nearing the end, okay? So let's talk about decentralization because this was a topic I studied before. Devolution is one form of decentralization. So what is the concept here? The concept is that by transferring decision-making authority from central level to local level, we enable local decision makers to decide for themselves, right? That's what happened with devolution. We transferred authority for the RHUs and the provincial health hospitals to the local governments. And the idea is that if you give the decision-making authority to the local level, they're supposed to be in a better position to know their needs and priorities better so they can respond in a better way to their own problems. And this has been a process that has been adopted by many countries for the past 2 decades. So in the Philippines, for instance, we did it in 1992. And okay, so let's look at the systematic reviews. What did they see when they examined the evidence on the effectiveness of decentralization? Kasi nga, the idea is that if you decentralize and you let them decide for themselves, that should improve the health situation at the local level. That was the one in theory. So next, these are 3 systematic reviews. Next. And all of them actually say, well, it's all mixed results. And in fact, there was little evidence. In some situations, decentralization was effective. In some situations, decentralization did not result in better health system performance. Next. So we reacted to one of those reviews, and in this short commentary, we said, well, first of all, what type of decentralization are we talking about here? Because we have to be clear, because decentralization in the Philippines is different from decentralization in Indonesia, and it's challenging to compare the two, for example. And rigorous studies for demonstrating effectiveness for decentralization is not always feasible. Can we actually do an RCT to examine the effectiveness of decentralization? Kunwari, we have this group of provinces as experimental. Sila lang ang devolve. Tapos, meron tayong group na control. Hindi sila devolve. Because oftentimes, decentralization is implemented as part of a political process and not an experiment. So this is an example where you cannot do an RCT. But just because you cannot do an RCT doesn't mean you cannot answer the question on effectiveness. Because effectiveness in this case is contextual. And so what we said here was that we need to build on these reviews, not to determine the best form of decentralization applicable for all settings, because a standard recipe for it does not exist, but rather to understand what makes decentralization effective for the health sector in some contexts and not in others. Next slide. So may I just invite you to look at this paper. So using a qualitative approach, we thought of a way on how we can assess the effectiveness of decentralization using the Philippines as an example. And in this paper, we said we have to look at 3 dimensions if you want to examine how to make decentralization effective. And that is the concept of decision space. And we have to examine the concept or the dimension of accountability, making local level decision makers accountable for their decisions. And then we have to look at the dimension of capacity, so that they should be capable to make the right decisions for the health sector. So if those three are always enhanced, then that's a pathway for improving the implementation of decentralization or devolution for health services. Next slide. So, okay, I'm gonna go back to this slide. So, it's not like this, no, where the more rigorous studies are more useful for policy and the less rigorous ones are less useful. It really depends on what the policy question is. Next slide. So, patapos na. So, for some takeaway messages, what I want to give you guys is that first, we really need research evidence if we want to improve health policies and programs. Next. But each research evidence, no matter the study design, it must never be interpreted in isolation, but always in the context of the body of knowledge about the topic and the realities on the ground. Next. There is no perfect study design. Each will have its advantages and disadvantages, but choose depending on what the policy questions are, and let the policy question determine the best research or study design to answer that question. Next. Oftentimes, the appropriate answer to questions about effectiveness of policies of programs is "it depends" or "we do not know yet." So if you find yourself quickly answering yes or no, then maybe it's better to think again. Next. And we do not have an answer to everything, because if we have an answer to everything, research is no longer relevant. It has lost its relevance. Next. And let me end by saying that science is a work in progress. What we know as true today may not be true in the future. Next. So I hope you were able to achieve our goal and objectives for this lecture. It's really for you to appreciate how research evidence can help inform policy development and program implementation in public health. And then specifically by looking at some of the study designs, we can understand how the strength of their evidence may help enhance health policies and programs. And we've discussed some case studies, and have them as examples for how research can contribute to health policy program analysis and action. Next. Thank you very much. Maraming salamat po.
Thank you very much, Dr. Harvy Liwanag, for that very, very engaging set of slides and lecture that you have provided to our participants. Our participants are all, or a lot of them are very engaged in the discussion. So for this Q&A part, I tried to sort of integrate or cluster the questions so that it will be also easier for us to look at them as a whole. I'll divide it into two main parts, Harvey. One part will be on the designs, and then the hierarchy of evidence, and then the other part of set of questions will be on the analysis, for which you looked into DOTS, deworming, and also some issues on COVID-19. With regards to the study designs, several questions on if this hierarchy of evidence is shared across disciplines and across journals. Questions on qualitative versus quantitative, which you actually addressed as well, in the lecture. Issues on reliability and validity, and whether and also issues on generalizability, so whether if a particular methodology and a particular topic can actually result to the same or a similar if you do it using a different methodology. The next set of questions related to study design is on the limitations, which you started to discuss as well. A question on if you use other methodologies instead of an RCT, will you achieve the same result? And a question on limitations relating to alternative medicine, specifically acupuncture. Whether how do you reconcile because the comment was RCT could be useful for Western medicine, but there might be limitations on the use of RCT when you do alternative medicine, for example, acupuncture. And also a comment on the non-inclusion of negative results when studies are being done. So I try to capture the related questions on study designs, and and give the floor to you now, Harvey, to sort of address some of those and probably integrate some of those in your lecture. Harvey?
Thank you very much, Doc Dennis, for the excellent moderation. Again, I'd like to thank our listeners for the questions. And for me, when participants ask questions, it's a signal that they're interested really in the topic. I'll try to answer them one by one as Dr. Dennis articulated them. So, yung hierarchy of study designs, I have to say that my background is epidemiology and health systems. So the hierarchy I presented here comes from the epidemiological tradition. So yung case control, cohort, these are really epidemiological study designs. And you know that epidemiology is the scientific discipline for public health, primarily, no? So that's the tradition I'm coming from. So are there other hierarchies out there? Maybe there are, okay? And I don't want to say that this is the official hierarchy for all study designs, because social scientists will, I'm sure, have their own set of study designs, and they can also rank them. I'm not a social scientist, so I'm not familiar, but you can also, you probably have your rankings also of which method is superior than the other, okay? The question on quanti versus quali. Thank you for this question. Personally, I started my training very biased towards quanti. And let's admit it, we still have researchers who look down on qualitative research, no? Kasi sa tingin ng iba, pag numbers yan, it's superior. Pero pag quali siya, it's like not as valid as the result. But I beg to disagree. When I trained in Europe, the perspective has changed already. We have to admit that there are questions which quantitative approaches will never be able to answer. If let's look at an example. Let's say we invented a scale for happiness, and the scale is 1 to 10. And let's say that Dr. Batangan has a score of 8 out of 10 in this happiness scoring system. That's quantitative. We measure his happiness. But what does that mean as a number? It's just number 8. But what does it actually mean when you say that? That's the one that can be answered by quali. What does happiness mean? Na 8 out of 10. So that will not be able, that cannot be answered by quantitative. So, yun na nga, that's why personally, my preference is that it should not be a question of either or. No, it's really good when we try to combine the advantages that we get when we do both as a mixed methods approach. And there are ways to do that, maybe in another time. So there are designs where you can combine them so that you start with quanti first and then you follow it with quali so that you can explain your quantitative results and vice versa. Regarding generalizability, well, of course, the statisticians among us will say that in order for results to be generalizable to the general population, you have to compute your sample correctly and you have to have a huge power in your sample size. That's true. So you can really just generalize the results if you do that and you follow the statistical rigors, okay? And this is only applicable for quantitative approaches. Qualitative research will not be able to produce generalizable results, okay? Because that is not the nature of qualitative research, okay? In quantitative, you arrive at an average that will represent the truth for that population. You don't do that in quali. In quali, you look at the diversity of perspectives. You highlight the differences in opinions and perspectives. So when it comes to generalizability, it applies only to quantitative research. But you might ask, if that's the case for quali, then isn't qualitative research very much biased? Kasi puro opinion lang, di ba? Yun ang criticism dyan minsan eh. Pero those of you who are into quali research, I'm sure you've heard of the concept of saturation. So there's a way, the concept of saturation in a way helps us, you know, when you do your interviews, for example, the concept of saturation says that when you keep interviewing and the same themes have been emerging, then maybe that that perspective is being shared already. So there are ways where you can do that in qualitative research. Ano pa yung ibang tanong? I don't understand my handwriting, but one of the questions was
On some limitations.
of
Limitations on the use of RCT with other methodologies, and also on the acupuncture, the value of RCT,
yes, okay.
limitation of RCT in traditional medicine like acupuncture.
So, halimbawa, let's talk about decentralization. No? For example, if you want to analyze the effectiveness of decentralization, we know that we don't have RCTs for that, as I already explained earlier. But we want to do a systematic review with the Cochrane Collaboration. So I invite you to go to the website of Cochrane Epoch. I think I mentioned it the other day. No, sa Cochrane Effective Practice and Organization of Care Group, or Cochrane Epoch. They have guidelines there on the hierarchy of evidence. So in situations where you cannot do an RCT, which is high quality evidence, so you settle with the observational study designs, for example. There's a case control ka or cohort, okay? There is still something to be learned there. But when you interpret your results, you keep in mind that because these are observational and they're not as rigorous as the RCTs, then the quality of the evidence is low. Okay, you interpret it in such a way. Okay, but it doesn't mean that it's not useful because it tells you something. Okay, so that's the approach there, and I will recommend that you visit the Cochrane Epoch website, and they explain it very well there. So if you cannot do an RCT, then these are the study designs that you can consider if you are still interested in showing effectiveness. For acupuncture, I think it should not be exclusive na dahil traditional medicine siya, hindi tayo pwede mag-RCT. Pwede naman, kasi if you want to demonstrate effectiveness of acupuncture, for example, in achieving certain health outcomes, you can actually do an RCT on that, no? And you will be able to show. And in fact, I think it is an important endeavor to be able to show that some of the traditional or complementary medicine approaches that we have actually result in better health outcomes, and you can actually demonstrate that if you do an RCT. And the non-inclusion of negative results, this is very true. There are studies because the results are negative, they don't get published. No, I remember si Dr. Eileen Duwalan, who is with Novartis, I think once told me that one of her dreams was to establish a journal of negative studies so that all negative studies will be published in this journal. So, but that's reality. There's a way to try to identify that, no, with the forest plot sa meta-analysis, and you can see there's a way when you do the meta-analysis and then you trace the studies na you can try to analyze and see na may mga negative studies ba na hindi nasasama dito sa natin sa analysis. So that can be one way that can be as one approach, no, to deal with this issue. I hope I am able to answer those questions.
Yes, very, very much, Dr. Harvey. So the next set or the last set of questions is actually on the issue of the different programs that you discuss on that deworming and COVID-19. And then after this set of questions, we'll proceed with the next lecture by Dr. Jason Ligot. So on the DOTS discussion, some mentioned about sociocultural aspects being considered with regards to the results, and also the variations in the implementation of DOTS as a factor probably within for which we could attribute the results for self-supervised DOTS and of course the traditional DOTS. For the deworming discussion, there was a comment on if the Department of Health is ready, that is what the question, to shift from the for a purely or a primarily drug treatment approach to a more preventive, more public health system approach, in terms of mass deworming in the country. So it was more of a program question. For COVID-19, the questions were comments also in terms of the masks, for example, and quarantine being part of a bigger or a more comprehensive or a more a broader strategy, to address the COVID problem. And there was a question on whether these policies related to COVID specifically were actually based on research or based on certain preferences or certain other bases, no. And finally, there were some requests, for copies of the DSWD study on for
The 4Ps.
yeah, 4Ps. And another request. Now, we also had this request last Monday for researches or copies of papers on researchers that were actually or that were able to influence health policies. So I think there were 2 or 3 requests on this. Probably we'll ask the secretariat to help us locate this, and probably we could send it out to the participants. And just a final note on, there were a lot of comments on mixed methods. And I would like to pick out one comment from Dr. June Gregorio. Mahalaga din yung kwento sa likod ng kwenta. So parang that's how he sort of framed the quanti-quali aspect. Mahalaga din yung kwento sa likod ng kwenta. So over to you, Harvey.
Thank you, sir. Is that Professor Gregorio of UPCPH?
Yes.
Hi,
yes.
Hi, sir. Thank you for joining us. I like how you said it, no? Mahalaga ang kwento sa likod ng kwenta. Where do I start? So deworming. Yung mass drug administration kasi, it's actually considered preventive chemotherapy. So it's a strategy endorsed by WHO. Kasi when you deliver the drugs sa school setting, you don't first test kung sino dyan yung positive for sole-transmitted helminths, di ba? You just treat everybody. And that's under the assumption that many are anyway infected. So the idea behind it is that's why it's called preventive chemotherapy, is that if you do it twice a year, doing it en masse, then you prevent further reinfection with STH. But I do agree that this is not enough, and I think for many years now we've been talking about WASH. And maybe you've heard of this, no? WASH, water, sanitation, and hygiene. We cannot eliminate sole-transmitted helminths if we don't address the WASH component. And again, it has to be a holistic approach to solve this problem. COVID-19, dun sa masks and quarantine. The question was whether this was based on research. I think so, as I presented it. No, the decision of the WHO to finally say that we are recommending the wearing of masks. It was based on research, that was presented, and they actually cite that study in their statement. The wearing of masks and the policy on quarantine as only components of a bigger part. I think let's go back to the concept of health systems or systems thinking, the concept that I introduced last Monday. No, when we approach a problem, we should be systems thinkers. No, the mask is just one part of our systematic approach to the problem. The quarantine is also. So there are many other components that have to be addressed if you want to control COVID. So you have to address testing, you have to address treatment, you have to address contact tracing, you have to ensure that the health workers are well compensated, well trained, motivated to treat the cases. You have to have good leadership, etc., etc. So that's systems thinking. So hindi yung puro silos na components lang. So that's why, yun na nga, if you want to address COVID, the mask and the quarantine, they're just part of a systemic approach to the problem. The study on the impact evaluation of 4Ps, you can easily Google it. I suggest you just go to Google and then type, you can probably type impact evaluation, conditional cash transfer, and then maybe put DSWD and World Bank. It's freely accessible online, so I'm sure you will find it. It's published in the year 2012. Papers that describe researches that have been translated to policy. Okay, so we will look into this and coordinated PCHRD so that we can share it at a later time. But I know that PCHRD also specifically the research to translation unit. No? So we're not just talking here of the publications, but also the current researches being published, being supported rather by PCHRD. Kasi nga, as part of 7Ps, no, it's important that when PCHRD funds a project, the policy translation is an important component of the project. So I think there is a plan to really have a mapping of all of the studies that have been supported by PCHRD, and then see which ones of these have been effectively translated to policy, and was that policy impactful and effective, etc., etc. So this is a work that we are planning to do, and then hopefully if we finish that, then we can share it to everyone. Yes, I think I answered the question.
Yes, Harvey. Thank you very much, no, for organizing again, no, the set of responses, no, for those questions, and thank you for the inputs that you provided this afternoon. Our audience, our webinar participants are very much engaged, and some of them are actually still asking for copies of the lectures for today and last Monday. So our team will get in touch with our.
But they can watch the replay, right? Because there will be a replay anyway.
Yeah, so there will be an email sent to them regarding the schedules for the replay. So thank you very much.
My pleasure.
Harvy Liwanag, and we'll see you again later when we end the session. So at this point, I'd like to introduce to you the next lecturer, you know, the one who will be giving us the inputs on communicating research effectively for policy development. So after we've gone through the inputs from Dr. Harvy Liwanag on how to look at or how to assess evidence, at what are the methodologies that are actually currently being used, no, to assess evidence, we'd like to discuss now how do you communicate these results, no, effectively for policy development. Dr. Jason Ligot is a public health doctor and international health communication specialist with working experience in health promotion, mental health, tobacco control, NCTs or non-communicable diseases, newborn health, violence and injury prevention, and environmental health. He has undertaken projects and assignments in over 15 countries for local and international health organizations, national agencies, NGOs, civil society, and educational institutions. These projects include high-level conferences, conducting workshops, and overseeing multi-country communication and advocacy campaigns. In 2020, he co-founded Protect the Frontline, a community campaign to mobilize equipment for COVID-19 frontliners. Dr. Ligot holds degrees in psychology and medicine, graduating with distinction, and has edited or contributed to scientific articles and technical publications on health promotion, health literacy, and communications. Currently, Dr. Ligot is a graduate student completing a graduate degree in public health from the University of the Philippines. So with that, over to you, Jason, for your input on communicating. The topic is communicating research effectively for policy development. Jason?
Thank you very much, Doc Dennis. And before I start, I'd like to say thank you to DOST-PCHRD for this opportunity, to the Ateneo de Manila University and IPC and the entire eTURO team for the great support in preparing for this lecture. And of course, to my friend, Dr. Harvy Liwanag, for the invitation to participate in this workshop. Good afternoon to all. So before I begin, I'd just like to turn off my camera because I think part of the challenges of doing these workshops in the new normal is you never know when the internet signal might get choppy. So I hope you don't mind that you won't be seeing my face for the next 40 minutes or so. I'll turn on the camera again during the open forum. So our topic for this afternoon is about effective communication for policy development. So over the past 2 days since the first day of this workshop series, we've heard a lot from our speakers, especially from Harvy, about the nature of policymaking, the nature of evidence, and the nature of research. So now that we have learned quite a little bit more about what evidence is and how it should inform policymaking, the natural next step is how do we then translate all of these research findings and communicate them effectively to our audiences, notably our policymakers. So Harvey had mentioned this during the first day of his lecture, but I'd just like to recap a few key points about how research can inform policy. And indeed, there are many different ways that research can inform policy. In the first instance, it can help identify critical problems, pointing towards issues that may not be at the high level of awareness of our policymakers. When it comes to describing or evaluating different policy options, research can describe the benefits and harms of different policy alternatives. It can also generate estimates about the costs and consequences of action or inaction. And in the context of COVID, we see how research does inform real-time decision making. Unfortunately, we also know that there is a gap between the body of research and the body of policy. And that can be due to several different factors. Could be because of differences in opinion, in perspective. There may be some institutional roadblocks that prevent this research from being translated effectively into policy. It can be due to poor communication, which is the topic of this lecture today, and other practical constraints. Now, zooming in on poor communication happens for also several different reasons. Maybe the information that is needed by policymakers is just not there, or they don't have access to it. Or on the other hand, you also have the problem of having too much information or too much data. There is an overload of information that policymakers are unable to navigate the sea of information to make effective decisions. Sometimes the information or the research is also presented in a language that is not understood by a non-technical person. And perhaps even after elaborating on the evidence, describing the findings very well, there is a lack of clear actionable messages. The so what? I mean, at the end of the day, this research should inform decision making. But if it's not clear what decisions need to be made, then that can result in poor communication as well. It is also possible that there is communication happening. There is a lot of research being communicated out there, but it is not the kind of information that is needed or that addresses the needs or concerns of policymakers. And I think one thing we should bear in mind is that we live right now in a very saturated communication environment. It's very, very noisy, especially with the advent of the internet and social media, where through a few simple keywords on Google, you can bring up oceans of information. There are also a lot of other people communicating, both within and outside the scientific community. And so, when it comes to sources of information for policymakers, we should not make the assumption, a very dangerous one, if I may add, that we are the only sources of information for policymakers. Policymakers also look at the evidence themselves. They also have staff, for example, that may come up with their own summaries. They certainly listen to the media. They listen to what is being discussed in community forums. They have their own networks of contacts and experts. They attend so many meetings. So I guess what I'm trying to say in this first few slides is it is important for us to be very strategic in the way we communicate, because otherwise it's very easy to be drowned out in the sea of messages and communication that is happening out there. So how do we do that? Here are 5 questions which I would offer that can help us come up with a more strategic approach to communicating research effectively. And by going through each of these questions systematically, we can come up with our own communication strategy, determine the appropriate messaging, the appropriate channels to reach the intended audiences, and hopefully narrow that gap between the research and the evidence and the policies that we wish to influence. So the first question is why? I think Harvey also referenced this earlier. In the hierarchy of questions, the why question is very important to ask. Why do we need to communicate in the first place? And from my experience in advocacy, usually you're looking for that perfect window of opportunity to influence policy. On the lower left, we know that there is an abundance of problems. You ask anybody what are the problems facing the country or facing the health sector, and you'll probably be faced with a litany of different problems. We have an abundance of problems. Thankfully, we also have, through research, a lot of solutions that we can offer to address these different problems. However, whether or not these problems and solutions are actually addressed is also influenced by the political environment. And it is only when these three things come together do we have a window of opportunity to bridge that gap between research and policy. So when it comes to answering the why, I like this framework because it then puts into perspective, first and foremost, what is the task of communication in this instance? And that task can be different depending on the particular circumstances you find yourself in. It could be, for example, that you want to communicate because you want to increase awareness or interest or understanding, not just among the policymakers, but among your stakeholders of a particular policy issue. On the other hand, it can also be about fostering consensus within the community of science, of research, on how a particular issue is framed, how we should work together, what's the best way for us to collaborate, and what's the priority. And then finally, again, reflecting a bit on the saturated communication environment that we find ourselves in, one of the important tasks of communications in evidence-based policymaking is to draw attention, to set the agenda. And we do that by working with other stakeholders such as the media, by working with opinion leaders, and other influencers. So, in the first answer to the first question here is, when you are reflecting on why do you need to communicate, the first thing you need to determine is what is your outcome. Now, in public health communication, we have this practice called determining your SOCO, your single overarching communication outcome. Now, bear in mind that the outcome is not the message. That's different, and we'll get to that later on. The outcome refers to the change you want to see as a result of communicating. And this should be very specific. It's not enough that the outcome is that the policymaker is better informed or is made aware. We should refer to specific outcomes. Do you want, for example, that the budget for this project or this program is increased? Do you want a specific piece of legislation to be passed? Do you want a policy that is already enacted to be implemented and maybe implemented better? So having a clear idea of the outcome of your communication will help you then determine your answers to the succeeding questions. So once you've decided on your communication outcome, the next question to ask is, who are you communicating to? Now, of course, in this instance, your primary audience segment are policymakers. And policymakers is a mixed group of people, but generally it refers to anyone with the authority to create or change a policy. It could refer to a government official, to local chief executives, heads of agencies, cabinet secretaries, even the president himself. And this is the primary audience of concern when it comes to evidence-based policymaking. However, there are other equally important secondary audience segments, and these are individuals, groups, or organizations that can either influence the policymaker himself or herself or the process of policymaking. And these are your advocates, the families or communities themselves, certainly the media, even the private sector, and other development organizations. Now, in marketing, one thing that they do upon determining your specific audience segment is they unpack this segment even further by describing different variables or different qualities of the audience segments. And these are just some examples. You can describe them according to geographic variables. Are you talking to policymakers in Metro Manila, for example, or is it Region 7 or somewhere else? Demographic variables, psychographic, and behavioral. And the two most commonly used ways of unpacking audience segments is through demographic variables. So these are variables referring to age, family size, level of education, their occupation, nationality, and psychographic variables, which is you segment audiences according to personality traits, values, beliefs, and lifestyle. Now, this is a very interesting study because we don't do this enough, in my opinion. But this was a study that attempted to segment policymakers when it comes to disseminating information or evidence regarding behavioral health interventions. And the conclusion of this paper is that messages that are tailored to audience segments are more effective than non-tailored broad messaging. And they came up with 3 audience segments among policymakers, which I think, even though this refers to behavioral health evidence only, can be applied to other health issues also. So on the one hand, you have your budget-oriented skeptics. So these are policymakers who are maybe as a result of stigma or other preconceived notions regarding the issue, are skeptical about any evidence or information that is being presented to them. And they usually evaluate information from a fiscal perspective. So the communication strategy here is to emphasize the cost of unaddressed health issues. So you speak to them in ways that they will understand or that they find valuable. So if they focus a lot on the numbers, you talk numbers with this segment as well. And then you have 2 groups of supporters as other audience segments, the action-oriented supporter and the passive supporter. For the action-oriented supporter, our role here is to provide concrete information about the evidence because they are already convinced, but yet they need more support in order to advance the issue from their point of view. And you reinforce their position through advocacy groups. For supporters who are not action-oriented or more passive, one way of communicating to them is to mobilize them through evidence, but also setting up platforms for engagement where they can interact either with their colleagues or their peers who are already action-oriented supporters, but with other audiences, your secondary audience segments that are on your side, for example. Okay, now the third question, very important, is the what. What are we communicating? And effective policy messages are, first and foremost, evidence-based. Second, they are contextualized. And last, they are action-oriented. And these qualities refer to the most common types of messages that are used when designing communication strategies around research. And they refer to findings, implications, and recommendations. So findings refer to the results of your research, and you don't have to communicate the entire body of results. What's important is that you select the most relevant to your audience, the most relevant to the policy issue. You directly link these findings to recommendations that you will make later on. And you ensure that these findings are presented in simple language that can be understood even by someone who does not have a technical background in research. So for example, while for us who are engaged in research, the minutiae about methodology, significance levels, alpha, etc., those are all very, very important qualities to consider when evaluating research. However, when you're communicating your findings to policymakers or those who do not have the same technical background, it will be important to translate these in terms that they can understand. Second, what are the implications? So it's not enough that you put the data out there. This data has to be put into context. Why is this important to see or understand now? How does this impact on the current policies that we have or the policy direction that we should pursue? It helps sets the agenda. Why does this matter and why is it important to address? And there are a couple of different ways or angles you can use to frame your implications. It could be, first, in terms of magnitude or scale. The findings that you're presenting, for example, has implications for all local governments all over the Philippines, or even bigger than that for every Filipino citizen. You can look at trends over time. This is a new finding that bucks the trend. For example, it is a different direction compared to what we expected to find. What are its implications on social or health outcomes? And whether or not these findings are related to existing goals or commitments. For example, the Philippines is a signatory to the UN Sustainable Development Goals. And as a result, we have certain commitments to meet those goals by enacting certain national policies or actions. So one way of presenting the implications of your findings is that maybe these findings have a relevance to how the government or how the Philippines will meet its obligations to these international commitments or instruments. Values and principles, costs or savings are also other angles that you can consider when coming up with the framing for your findings. And then finally, make sure that you don't end your communication with just the findings or the implications. Don't leave your audience hanging and come up with recommendations that have very specific actions to address the policy issue that are supported by the findings that you presented earlier. And I think this is an acronym that we're all very familiar with. They also have to be SMART, meaning they are specific, measurable, action-oriented, realistic, and time-bound. So at this point, you already have an idea of why you want to communicate, whether it's to increase understanding of a particular policy issue, to foster consensus, or to raise general awareness, and who you're communicating to, whether you're communicating to the policymaker directly or to other audiences that may influence the policymaker or policymaking. And you already have your set of messages. The next question is the how, and how refers to the channels that you will use, the tools that you will deploy, and the materials that you will develop. Now, generally speaking, in communication, we have 4 different communication channels. So the first channel, and the channel that we usually use when it comes to communicating research for policymaking, are interpersonal channels. So interpersonal channels are one-on-one communication, maybe directly to a policymaker or between peers. And these include meetings, developing policy briefs, which we'll discuss a little later, and writing advocacy letters. A community channel is a channel that reaches a group of people with a shared interest or common characteristic. And examples of community forms of media include newsletters or emails. So this is actually a very powerful channel that I think we should always consider when it comes to planning our communication interventions. Because people usually opt in for these channels. They subscribe to these newsletters. They receive the emails because they are part of a specific organization or group of people. These also include convening town halls, conferences, and the like. Mass media is a channel that we're all very familiar with because these are channels that reach a large audience in a short period of time. So these include television, radio, and print media. And last but certainly not least are your digital or your social media channels, which are channels that allow people to create and share content and engage in social networking. So websites, social media platforms such as Facebook, YouTube, Twitter, LinkedIn, and Instagram are examples of these channels. So once you have selected your channel, you then now proceed to select what are the different tools that you use. I won't go through all of these different tools one by one. Instead, I will highlight a couple of tools that are relevant to our particular topic today. So advocacy is obviously a very relevant tool here, and you use advocacy when you want to shift public opinion or you want to mobilize resources. Another important tool is events and sponsorships. Here is where you organize a meeting or a conference to call attention and convene your stakeholders around a particular issue. So, and this is something that we do very often. For example, when we organize our research fora to present latest findings to audiences of interest. Community participation is also very important, especially from a health promotion point of view, where you want to build a movement and you want to engage different stakeholders around this particular issue to support the evidence that is being presented and also to support the advocacy. And then once you have determined your channels and tools, the last bit is determining the kinds of materials that you will produce. And generally speaking, you have materials that have very limited reach, such as policy briefs, newsletters, posters, and those mass reach materials, such as television ads, radio ads, newspapers, magazines. And one set of materials is not necessarily inferior to the other. It all depends on your particular objective, your target audience, and the kinds of messages that you need to put out there. Now, on the right is an example of how all of these different elements come together. Now, back in 2016, we convened an event for World Health Day. So every year in April, we celebrate World Health Day, which is the founding anniversary of the World Health Organization. And back in 2016, the topic then was on diabetes, because it coincided with the publication of a global report on diabetes, which also included some new recommendations regarding cutoff scores and policy options for governments. So in order to highlight the findings from this report and to raise awareness around diabetes, on the lower left, we convened an event. So that was the event that was convened at the WHO Regional Office for the Western Pacific, wherein we convened policymakers from our member states to present the findings from the report, but also to provide a venue for them to dialogue with the experts or the scientists that were behind the new technical findings. But to complement that, we also use social media. So on the lower right is a photograph of our host, Mr. James Chow. So James is a TV personality. He was rather a news anchor based in China, who we invited to moderate the event and also streamline the event on his social media platforms to his followers. So he was actively posting about it on Facebook and Twitter and other social media, and that just expanded the reach of the messages. And then finally, on the upper right, we also convened a press conference. So here is a photograph of our director talking to the media about the report and also about World Health Day. So I think the message from this slide anyway is that while you have to be very strategic, it doesn't mean all of these different channels are not mutually exclusive. In fact, they work best when they complement each other. Okay, and last but not least is you have to determine, after having launched all of those different communication events, materials, etc., are you communicating effectively? And here's a very simple M&E approach for your communication, which describes different dimensions of data and information that you would probably want to collect both formally and informally to determine the effectiveness of your communication. So first and foremost, of course, you need to monitor your audience. So in the population level, we do this by recording changes in knowledge, attitudes, and practice. But on a more one-on-one individual level, sometimes we rely on descriptive information. We rely on informal interactions, for example, with staff, with technical staff, or policymakers, or the policies themselves, to determine whether or not there has been a change in their position or their point of view. Second is you want to monitor your reputation. You want to know if you are the go-to source for this particular topic. How many inquiries are you receiving? What is the perception of your organization? Are you perceived to be an accurate source of information? Or, because again, we are competing in a very crowded communication space, are people asking other individuals or organizations for that information? You want to monitor relationships, and this can be as simple as the frequency, the content of meetings. Are the policymakers, for example, agreeing to meet with you on this topic? Is your research being placed on the agenda? You also want to monitor public opinion, and you can do this both formally through surveys, for example, or focus groups or interviews, but also informally through social listening by trying to discern what people on social media are talking about and whether or not they're talking about this issue in a positive or in a negative way, and using that information to calibrate your communication. And last but not least, you also want to monitor the media, because the media is a good, first of all, they're very powerful in terms of the extent that they can influence public opinion, but also the opinion of policymakers. So you want to record how much media is being generated, or rather how much coverage is being generated around your issue. You want to describe the frequency, but also the content of the media coverage. Is media reporting on this issue in an accurate way? Because if they are not, then maybe part of the communication effort has to be directed towards them in increasing their awareness and understanding of the issue. Okay, so in this last few slides, one of the contexts that we are communicating in is this post-truth era, and I'll talk a little bit about that towards the end. But to introduce that topic, I just wanted to highlight this very simple but very powerful model in communication, which refers to the hierarchy of communication effects. And according to this model, communication has three broad effects on anyone. They can be cognitive, affective, or behavioral. So first and foremost, communication is effective in raising awareness. We all know that. And then also in transferring knowledge and building skills. But it is not enough, for example, for you to reach behavior if you only focus on this level. And this is where sometimes a lot of the criticism around communication, public health is concerned. Our primary goal sometimes is always just about raising awareness. But we know that communication also has affective or emotional effects. So it's not enough that people are aware or knowledgeable about an issue. They have to like it. They have to associate it with positive values. In the sea of opinions and options, this particular recommendation must be preferred. So they must select it among the different options. They must be convinced that this is the right position to take. And it's only then that they will create action. In public health communication, we also have a similar model, if you will, and they refer to the 7 C's of effective public health communication, which are being shown on your screen now. So in order for you to raise awareness, you have to command attention. When you're transferring knowledge and building skills, the message has to be very clear. If you want them to associate positive values towards the opinion or the recommendation that you're presenting, you have to convey a benefit and be consistent. If you want them to prefer it among the different options, it's not enough that we cater to the mind through facts, but we have to cater to the heart as well through storytelling, framing. And in order for them to be convinced, there has to be trust between the messenger and the receiver. And once you've achieved all of that, it's only then can you have a call to action. So I introduced this not to say that in every instance when you're thinking about communication that you have to go through the different steps, although that certainly can be useful. But it is a good reminder, for me at least, about how hard we need to work in order to communicate effectively. Because it's not enough for us to be working only at the upper left, where it's about making a lot of noise that will certainly raise awareness and command attention. We have to go through all these different steps before we're able to motivate a policymaker, for example, to act around our recommendation. Okay, so I said we are living, or rather we're communicating in a post-truth era. What does that mean? There have been a couple of articles written about this, and this one was a discussion published in Health Promotion International. And they said that a post-truth era refers to circumstances in which objective facts are less influential in shaping public opinion than appeals to emotion and personal belief. And that can be very tricky for us because evidence are objective facts. So how do you then communicate these objective facts in an era where they are perhaps seen less, in a less relevant manner by the people we wish to influence? And this was also a point that was made earlier during day one, that policymaking nowadays is not a linear process. In fact, it's very circuitous and it's very dynamic, subjected to many different pressures at different times, often involving different actors with their own sets of motivation. So, suffice to say, you're trying to communicate in an environment that is, first, very crowded, you have a lot of competition. Second, in an environment that may not actually respect facts as much as they used to, and in an environment that's very dynamic where you can go from step 1 to 3 and then the following day go back to step 2. So how do we communicate in such context? And we know that we have examples of these problems, such for example, the anti-vaccine movement, where despite the abundance of objective facts and evidence and the benefits of vaccinations, you still have a significant proportion of the population who refuse to vaccinate their children. And even worse, they advocate for other parents to do the same. And this is also the era where you have companies such as tobacco control companies are using new tactics for manipulation. Philip Morris, for example, launched a smoke-free future campaign, presumably to describe how their company will evolve. But this is just another example of manipulation by this industry. So these are the kinds of contexts that you may find yourself in when you're communicating the evidence surrounding your policy issue. So what do you do? First, generate high-quality evidence. I think that is very much well within our control as researchers, as scientists, or as members of the scientific community. We have to conduct high-quality research in order to generate evidence that is unimpeachable. And we do that by adhering to and maintaining high standards throughout the entire process, all the way from coming up with a proposal to gathering your data, to analyzing it, subjecting it to peer review, and disseminating the findings. If anything, this is perhaps one of the biggest responsibilities of people working in public health research nowadays, is to do good quality research. Second is we have to strengthen our institutions. And this refers to the formal institutions that we have. PCHRD, for example, is one, but also to our communities of practice. So these may be informal groups that we form with like-minded colleagues or peers. And this also speaks about our individual reputations, and that is something that you cultivate over time. But one of the challenges that we have, of course, is sustainability of research activities. So I particularly want to applaud the efforts of PCHRD in this regard by convening these kinds of webinars to build our own local capacity and really strengthen the institutional capacity of different groups, organizations throughout the country. We have to foster evidence-appreciative populations. And this is maybe a rather sensitive issue or point to make, but let's face it, there is a tendency for people like us in the scientific community to be very paternalistic when it comes to communicating our evidence to the audience out there. Many times I find many times, unfortunately, the messaging is, we know better than you, so you better follow us. That is no longer the case. And maybe the challenge for us is to listen as much as to speak to these populations. Understand where they're coming from, what are their fears, what is their particular context, and to link the evidence to their daily life. Why is this important to you? Why is this piece of information important for your family, for example? And last but not least, I think we should not be afraid to speak truth to power. If, for example, you have gone through the necessary rigors of generating good quality evidence, the data that you have was generated through ethical and rigorous means, and you have all of these objective facts on your side, we should not be afraid to speak and to make sure that this data is heard by the people who have the capacity to make things happen, to change. And one way of doing that is, of course, engaging with the politicians, with the policymakers, and the people in general through very convincing narratives. We should not make the very dangerous assumption that simply because we put the message out there that it is automatically understood. We have to meet them at their level, for example, and try to come up with good ways of framing the arguments that makes it relevant to their particular context. And I particularly like this line from this article, that we have to be fearless in communicating science and evidence, even if it differs from the point of view of the majority. I have personally found myself in this particular situation where my opinion or my point of view, even though it is backed by evidence, it is not shared by the room or by the group I'm talking to. Having said that, I find it is still our moral responsibility as public health practitioners, as people of science, to be fearless in communicating the science and the evidence. I think that is a very important thing to highlight. Certainly, sometimes it can feel very frustrating and very lonely, and that's something I'd like to acknowledge at the onset. But I think over time, the responsibility of being of having all of this evidence and making sure that they're translated to policy does fall on our shoulders, and we should take that responsibility seriously. Not to say that any of you don't, and I think the fact that you are here with us today is just evidence that you do care and that this is an important issue. Now, the diagram on the left is the classical diagram from the Ottawa Charter. So my particular area of work is in health promotion, so I care about health promotion very deeply. And whenever I do feel lost or I do feel that unsure, I just reflect back on some of these very key, simple but elegant principles from the Ottawa Charter about what is our role in building healthy public policy. And there are three actions here. It is about enabling. So it is about building capacity. It is about empowering people, policymakers, to make informed choices. It's about mediating. So even though you find yourself in opposite sides, it is our role to mediate and try to reconcile those differences. And last but not least is to advocate, which is about communicating the science and the evidence. Okay, so I'm going to stop there. And I believe in the program we have a 10-minute break. And there will be a couple of videos that will be shown during that break. So please take some time to take a bio break, relax, maybe stand up if you've been sitting down all this time. And we'll resume the second part of the presentation in 10 minutes. Thank you.
In this time when we are filled with questions, fear, hesitation, and anxiety, there is one thing that remains strong and which we can rely on. It is science. With the truth as its method, science can create bridges of answers and tread new roads toward discovery. Science can subdue disputes, end doubts, fill deficiencies, make affordable services and technology, shed light on questions, ensure our safety, and unify dispersed forces to eradicate the pandemic. Throughout our history and life's challenges, we had overcome the greatest crisis in the world. As we turn to science and technology, together we can triumph over this period. We shall write a new history and an era of healing. In this time when we are filled with questions, fear, hesitation, and anxiety, there is one thing that remains strong and which we can rely on. It is science. With the truth as its method, science can create bridges of answers and tread new roads toward discovery. Science can subdue disputes, end doubts, fill deficiencies, make affordable services and technology, shed light on questions, ensure our safety, and unify dispersed forces to eradicate the pandemic. Throughout our history and life's challenges, we had overcome the greatest crisis in the world. As we turn to science and technology, together we can triumph over this period. We shall write a new history and an era of healing.
Okay, thank you very much. And I hope you found those videos helpful. Certainly register for the Herdin account if you haven't. And I think you can ask some more questions about other services that might be available to you as a researcher from PCHRD at some point in the program. Okay, so for this part of the next part of the lecture, I will be talking about a specific tool that we use to communicate evidence for policymaking, and that is the policy brief. The policy brief is a document that you prepare to talk about a particular policy issue. So what is a policy brief? You can take it from the name of the document itself. So it is a piece of communication that is very short and concise, addressed to a policymaker typically, about a particular policy issue, presenting the evidence around it, and recommendations. So it is a document that is not meant to be exhaustive. So I think that's a very important point to make. You may have an opportunity at some other point to communicate or to present a longer document. But a policy brief is meant to summarize large amounts of information for the policymaker to understand who are the different stakeholders involved in this particular policy issue. What are the relevant findings from research? What are the policy recommendations? And what are the costs and benefits of different policy alternatives? So it is designed to facilitate the use of research or evidence in the policymaking process. Now, there are 3 ingredients to effective policy briefs. So first and foremost, they have to be based on evidence, and that evidence has to be communicated in a persuasive manner. So it has to have a clear purpose, the arguments, and all the other pieces of data and information have to be coherent. There has to be transparency in describing the evidence, who funded this research, for example, who are the people behind it. Dr. Liwanag in his earlier lecture talked about the different forms of study design and the quality of evidence that is as a result of those different study designs. And they have to be communicated with authority. And this has to do with who the messenger is. So the messenger has to be perceived with credibility in the eyes of the policymaker. Second, it has to address a specific policy context. So earlier we talked about determining our specific audience segment. So the policy brief has to address a specific audience segment and provide what that audience segment needs. So it has to address a specific context. This is meant for a national level policymaker, a subnational level policymaker. Is it more a health policy issue, a social policy issue, some combination of both? And it has to present actionable recommendations. So clear and feasible recommendations on the steps to be taken. And then finally, it has to be engaging. So the language that it is written has to be very clear. The writing style has to be accessible. It does not present information in technical jargon that is not very accessible to many audiences. It has to be visually appealing. So that adds to the credibility of the document itself, whether or not the document looks polished, well laid out, And you don't only communicate using words, you can also communicate the information through charts, graphs, photographs, and other forms of visual language. Now, these are the typical contents of a policy brief. And if you go online, there are actually several different formats. But I wanted to show this particular format because it's quite comprehensive. And if you follow or you ensure that your policy brief has contents for each of these different sections, and more or less you can be confident that it is a complete brief. Some parts of these, though, actually are presented in under one section of a brief, so they're not necessarily very distinct sections of the document. And so the very first component is the title. It sounds simple enough, but actually the title can make or break a policy brief. It has to be attractive. So policymakers receive reams of documents on a daily basis, and either themselves or their technical staff have to wade through all of those documents. And I recall during the early parts of the COVID-19 pandemic, for example, there was just an explosion, if you will, of documents, guidelines, recommendations, etc. that I think at one point the WHO called it an infodemic. We were drowning in a sea of information. So that should give you some insight to what would be an effective way of communicating to a policymaker. And one way to ensure that your policy brief gets picked up is to have a very interesting title. So it has to describe the content clearly, it has to be interesting and relevant to the target readers. So this is a policy brief issued by Epimetrics in the Ateneo School of Medicine and Public Health. This is part of a longer series of policy briefs called prescriptions. So these are documents that they have been issuing to provide technical guidance regarding different aspects of the COVID-19 response. And this particular brief is about nudging. So for those of you who have not heard of the term before, nudging is a behavior change intervention that you use on a population level to influence the technical term that they use is choice architecture. Basically, what that means is you influence the choices that people make in order to nudge them to make the choice that will promote their health. So I found the title to be very clever, A Nudge in the Right Direction, How to Encourage Protective Behavior Against COVID-19. There's a slight play of words, but it's also very clear that this particular prescription is about behavioral interventions as opposed to the other prescriptions that were issued in the series. Now, every policy brief usually starts with an executive summary. So the policy brief is already a brief document in itself. It should be very short, no more than maybe a few pages, maybe 3 or 4. But even then, because again, policymakers and their technical staff have to go through so many volumes of documents, you still have to have a briefer version of the brief, if you can call it that. And that's what the executive summary is. So it is a synthesis of the entire brief. It provides a complete and fair understanding of the issue. It clarifies the objectives, what the problem is, and a concise view of the different alternatives and recommendations. So this was a policy brief issued by the UN Interagency Task Force about tobacco control in Myanmar. And this was part of a series of missions that the UN had been mounting to different countries to make the investment case for tobacco control. It is an interagency task force. As you can see, there are different logos represented in the masthead of the document. And the main point here is they go to a country, they talk to different stakeholders, they gather data, and then they present an analysis in the form of an investment case. So this document had this box, which you can see on the right, that describes what an investment case is, which is the mission that they mounted. Why was it conducted? So was it at the request of government? What is the objective of these missions? And what are the key findings? So this box was on the front page of this document, which was, I believe, around maybe 5 or 6 pages long. But on the first instance, you can already see and read what are the key points from the document. Now, the next two sections, the introduction and the context, are usually in the same section, so they don't necessarily have to be separated. But these are the opening sections of the actual document itself. And here, because this is the first part that your reader will appreciate, what you want to achieve here is you want to get the interest of your reader right away. You have to describe the context or the nature of the policy issue. Why is it important for you to read the rest of these documents? It's actually very important as well that this is written first in a language that is very accessible, again, not too technical, not too filled with jargon, and it presents a good or interesting frame for why this policy brief was issued in the first place. Now, this is the opening paragraph of a policy brief issued by the UN on COVID-19 and the need for action on mental health. And let me just read to you the first sentence. Although the COVID-19 crisis is, in the first instance, a physical health crisis, it has the seeds of a major mental health crisis as well if action is not taken. I think that's a very elegant written sentence. It immediately gives you a sense of urgency. In your head, you already try to anticipate, oh my gosh, because it puts it into perspective. COVID-19, the physical health issues, the infectious health issues has affected everything about our daily lives, but actually it has the seeds of an even bigger crisis on mental health. So it propels you to read even further. And that, I think, is a good introduction to a policy brief. At the same time, this opening section has to describe the context. So the context can refer to either the political backdrop of the policy briefs, at what stage of the policy process are we in? Are we in the very beginning? Are we somewhere in the middle? Are we almost at the end? It also describes the stakeholders and the populations that are involved in this particular policy issue, and at what level is the issue being analyzed? Is it at the national, provincial, or local level? This was This is a policy brief that was issued by the CDC on violence as a result of road traffic crashes. But in particular, this policy brief was written as a response to road traffic crashes in rural areas. So you can imagine that the density or the volume of road traffic in rural areas is not as much as cities. Having said that, that doesn't mean to say that they don't suffer from preventable injuries as a result of crashes. And so this particular policy brief places the data and the recommendations contained in this document within that context, that actually, people living in rural areas apparently have higher rates of passenger vehicle occupant deaths and a higher proportion of unrestrained deaths. So people who drive or are passengers in rural areas in the US apparently don't use seatbelts as much as people driving or riding cars in the city. So that already gives you an idea of how you should appreciate the rest of the document, the data that will be presented, and the recommendations. Okay, and now the next two sections are the meat of your policy brief. So first is the definition of the problem, and this section puts some level of detail on what the problem is. It identifies, defines, and explains the nature of the problem. Helps convince the reader why this problem is urgent and why this brief will provide possible solutions. But I think the most important point to make in the definition of the problem is the problem has to be put into context that it requires government intervention or whoever that policymaker represents. Certainly, there are many problems that need action, but not all problems are appropriate for government action at different levels, for example. So the problem and how it is defined has to be written in that way. So this is an example of a policy brief issued by UNFPA as part of the COVID-19 response. And UNFPA, or the UN Population Fund, has a long history of work dealing with communities or individuals, organizations, looking after the health and well-being of women and adolescent girls. So, in this particular policy brief, they present the problem within that particular context. What are the particular needs of women and adolescent girls during this pandemic? And why that requires government intervention, and who should be acting and what should they be doing? And of course, after describing the problem, you then go on to describe the evidence. And the evidence here has to be clearly linked with the recommendations that you will present later on, but it also has to be presented in a convincing way. So again, the language has to be very accessible. A very common way of framing is to reduce the numbers into numbers that people can more easily understand. Saying, for example, 1 out of 4 poor PWDs is a child with disability. Out of 1.5 million children who need assistive devices, only 5% have access to assistive technology. So it is finding ways of making these numbers or this data more easy to process. And then the last two sections of your policy brief is where you present your proposal or your recommendations and your conclusion. So this is where you provide a concise synthesis of the most relevant findings. You present implications or recommendations, including the notes of feasibility. So again, here I'd like to kind of differentiate those three kinds of messages that we usually communicate. So findings refer to the results of your research. Implications refer to the context of this data and why this deserves attention. And then recommendations are action-oriented steps, your call to action after presenting all of this research and this data. So here is a very interesting example, because this is a series of policy briefs issued by UNDP and the WHO on non-communicable diseases. And for NCDs, one of the challenges and what makes NCDs very difficult to address is the need for multi-sectoral action. In NCDs, we often have to coordinate and to advocate to sectors outside of health. So you want to advocate to the finance sector, for example, on issues such as taxation of tobacco products and alcohol. In this instance, we want to advocate to transport ministries in coming up with different forms of active transport that actually encourage physical activity, that is safe, etc. So this was designed to come up with very specific recommendations depending on the particular ministry that they were addressing. So of course you have to do the same. In your policy brief, it's not enough that you come up with a catchy title, you present the findings, but at the end of it, what are your recommendations and what should I do? And so that's the last section of the policy brief. What type of change or policy and actions is recommended? What are the implications if you do what you recommend, and also if you don't? And you have to describe clear next steps. And this last section is sometimes very sensitive to write, because not all policy briefs are also welcomed by policymakers, especially if you are issuing them with not as a response to a particular request. So this is a series of forecasts that the University of the Philippines has been issuing since the beginning of the pandemic. And it typically begins with a description of the methodology and an elaboration of their model. And then they describe what their forecasts, for example, for the next month, presenting different scenarios. And then it ends with a synthesis on what their recommendations to government is, and what the recommendations for other sectors. And on a practical note, never forget to put also your contact information. That's very important, but sometimes forgotten detail. You communicate all of these different issues, and you raise awareness, you generate interest, but then if the policymaker does not know how to get back to you, or his staff does not know how to get back to you, then that can be a problem, obviously, especially if you want to cultivate a relationship. Okay, at this point, this is the last slide of this lecture, and which is good because we made up for some lost time earlier. And I'd like now to ask our colleagues from PCHRD to play a video, just a short 5-minute clip about I think it's a very good example of how research was translated into policy that got translated into global action that has made an actual difference in our everyday lives. And I'm referring here to the Kyoto Protocol, which was a global treaty that was negotiated a couple of decades ago to address the problem of the ozone. So I know that this webinar is was organized for early career researchers. So for those of you who are younger than some of us, this may not be a top of mind issue, but I remember very distinctly when I was very young, reading an article presented in Time magazine that had a picture of the ozone hole over the Earth. And that just that was very, very scary for me at the time. And it was a very interesting article to read. So I just wanted to share this as an example of how how this entire process was carried out for that particular point in history. So if I could ask our colleagues from PCHRD to please share that video. And then after that, I think we'll proceed to the open forum. Thank you very much.
My search for answers will lead me to the scientists closest to the issue, who discovered the hole, and those who've Okay, sorry for that. I think we're having some technical difficulties. So if you give us a moment, we hope to get this been
video.
studying it ever since.
Okay,
First stop, Cambridge in the UK. The British Antarctic Survey has been monitoring ozone levels since the 1950s. Jonathan Shanklin was one of the first to notice that something wasn't right.
When we made our discovery, ozone had then been monitored from the Antarctic for nearly 30 years. That we had a whole stack of handwritten sheets where the basic numbers from the instrument had been written down, but they hadn't been processed to give the ozone amount. And so as a young graduate, I was given the task of supervising all this and coming up with the answers. What I did was plot out the lowest 11-day running mean value each Antarctic spring. Ozone levels seemed to be falling off the charts, and at that point, the other members of the team, Joe Farman and Brian Gardner, came up with a paper that was published in Nature and showed something really strange was going on over Antarctica.
The ground measurements showed that every year, the spring total ozone levels would dramatically fall over Antarctica. As my travels lead me to NASA's Goddard Space Flight Center, I learned that this disturbing trend was also being confirmed by observations from above.
It was shortly after that the first pictures of the Antarctic ozone hole came out from the satellite data. Remember that a ground station just looks up and sees one spot on the Earth. But the satellite gives you a global picture of total ozone, and that's where the name ozone hole comes from. Looked like a hole had been punched through the ozone layer.
In retrospect, that was a really good thing to call it, because an ozone hole must be bad. Almost automatically, it meant that people wanted something doing about it. The hole had to be filled in.
Ozone has a natural regulation process, but something was throwing it off balance. Our use of certain chemicals, most notably chlorofluorocarbons and halons.
Chlorofluorocarbon is a very non-reactive gas. You can breathe it, and it doesn't affect you at all. But when you release this gas, it gets fairly well mixed in the lower atmosphere, and then it leaks into the stratosphere. And these chlorofluorocarbons get above the ozone layer, actually. So they get broken down by that intense solar radiation that's sort of beyond the ozone layer. Now, once they do that, they free a chlorine atom. And the chlorine atom engages in a little catalytic reaction. It will react with ozone, and then it will react with another oxygen atom to regenerate itself back to chlorine. So one chlorine molecule in a little cycle can destroy thousands of ozone molecules.
If ozone-depleting chemicals were being released all around the world, why was there so much chemical destruction of ozone happening over Antarctica?
During winter, the stratosphere in the polar region is very cold, and so temperature can reach about minus 80 degrees. And in these conditions, clouds are formed. They are called the polar stratospheric clouds. And on the surface of these clouds, there are chemical reactions that convert chlorine compounds to very efficient compounds.
That the air cools. As it cools, it sinks. And as it sinks, it begins to spin. And this sets up what's called the polar vortex, stopping exchange with the outside and turning the center of Antarctica into a giant cooking pot, where all the chemistry takes place that destroys the ozone. We certainly thought that the discovery would shake a lot of groups up.
It's being called an unprecedented display of international cooperation to protect the world's environment. The Montreal Protocol, signed today, aims at stopping the deterioration of the ozone layer in the atmosphere.
The Montreal Protocol was really a landmark agreement, and it really required a scientific foundation. That is, you had to have solid science that formed the basis of the Montreal Protocol. And then that fed upward to policymakers, government policymakers, politicians, industry people, technologists. How, if you got rid of chlorofluorocarbons, how did you substitute for those chlorofluorocarbons? All those groups came together, and in 1987, they negotiated the Montreal Protocol.
It's quite amazing that every single one of the UN member states has signed up to the treaty, and it's working.
By the mid-1990s, the production in developed countries of these ozone-depleting substances had been largely stopped, and now, even in developing countries, chlorofluorocarbons are no longer produced.
In their place, transitional substitutes have been introduced.
Okay, thank you very
These being
much to
revised
our colleagues from PCHRD for playing that. Again, thank you to DOST-PCHRD for this opportunity to speak, to share some ideas with all of you. Thank you to Ateneo de Manila University and IPC and the entire eTURO team for convening this webinar series, to Dr. Dennis Batagan for moderating this discussion, and to Dr. Harvy Liwanag for the invitation. Thank you very much, everyone, and stay safe.
Thank you very much, Jason, for that very enlightening lecture. A lot of our webinar participants actually posted their very positive assessment and feedback on the lectures, the two sets of lectures that you gave. So I divided the questions. So I sort of clustered them and divided them into two main areas. Mm-hmm. One is on the main lecture that you gave on looking at research and policy gaps, and the other one is on policy briefs. So for the first set of questions, there were questions around operational issues, also on methodology issues and audience, questions on audience, and a lot of a bit of comments on the post-truth slide that you had. No, for the operational issues, there was a question on what if there are several groups taking on or addressing a particular issue, but not singing the same tune. No, how do you handle this? And then there were also issues on costs. No, what, for example, they were saying that preventive interventions usually would have a difficulty of showing that it's cheaper than the other interventions. And then there was a question on DOST. Probably we could ask Yuli to answer this later. Whether cost of advocacy to institutions can be included in the budget as part of the research outputs. For the methodological issues, there was a question of do we have evidence to show that policymakers listen to researchers? And the other question is, how do we evaluate the impact of effectiveness and communication? How do we have the impact and effectiveness of communication strategies? Perhaps we'll do that first set first, and then we'll go to the next set of questions. Okay.
Thank you very much, Doc Dennis, and thank you for all of these great questions and for the compliments. I really appreciate them. I think when you are in a particular policy issue that there are a lot of different advocates, maybe advocating for the main broad issue but having different ways of attacking it or different perspectives. First, the question you have to ask is, what is your role in that group? If you are the convener of that group, then I think it is your responsibility to forge some kind of consensus within the different groups or stakeholders that are represented. And that can be done through dialogue, certainly, through other forms of participation, and through evidence. I mean, I think that is the spirit of a peer review process. So a peer review process is, in research, is usually, it's a blind process, right? You submit it to a journal, and then the editor gets back to you with comments. Most of the time, at least my experience has been with comments from authors that are not named, but presumed to be your peers. But a stakeholder group or similar discussion works in the same way. You have to advocate to your peers, and you have to form some form of consensus. The other way of looking at it, obviously, is if for very big policy issues, there are different angles and different sub-issues concerned. And maybe it is less about having one message, but ensuring that the particular stakeholder or group that is relevant to that sub-issue, their efforts or their energies are directed that way. Now, if you are not the convener of the group, instead you are a member of the group and you have your own position that is different from the others, then again, it's the same. It is subjecting yourself to the peer review process, if you will, and convincing your other members or other groups there of the validity of your own point of view, the strength of the data that you have, and also the weight of the evidence that you bring to the table. Now, having said that, I think sometimes the most difficult thing about communication is less about what we say, but how we listen. And I suppose having an open mind and going to these meetings in these groups with a very broad and open perspective is always helpful. We should not presume that we always know all the answers. Other people may have different answers to the same problem, and it is incumbent upon us as members of a scientific community to listen and to dialogue. About the costs, yes, that is something that is it's a very relevant question to ask, and maybe it can be answered again through research. If we don't know the cost of certain interventions, then that's, I think, a very excellent topic for research to find out. There are other schools of thought that we can, or bodies of knowledge that we can access, Economics is one of them, working with health economists to derive some form of cost-benefit analysis is always very useful. This is the spirit behind these investment cases where teams of experts, one of them, usually an economist, goes to a country and tries to understand an issue from different perspectives. And maybe this is a question that the DOST can answer, but I recall that in at least in the research proposals that I have participated in, there is usually a budget item there for dissemination. And this can refer to attendance fees, for example, in conferences, if you're going to present a poster, publication fees associated with getting your paper published in a journal, in case it is a journal that charges these kinds of fees. So definitely, I do agree with that point, and you have to budget for the appropriate amount to ensure that you're able to communicate your findings effectively. Do policymakers listen? I think they do, and I would rather adopt rather the attitude that policymakers are open to evidence. And at least with the policymakers that I've had the privilege of interacting with, most of the time, actually all of the time, they do appreciate evidence. It's just that I think where sometimes we fall short is how we present that evidence to them. So going back again to some of the earlier slides that I discussed, that evidence has to fit their particular need or context. You know, if I'm asking you this one question, but then you come up with an entire encyclopedia on the origins of this particular science, then that's not really helpful, isn't it? So you have to meet them at their needs and their context. Just be very clear on what your objective is when communicating to a policymaker. And there are many different ways of evaluating the effectiveness of a communication strategy, but as many of you probably know, before you even attempt to design an M&E strategy, you have to be clear on what the outcome is. What's the outcome of this communication or this communication strategy? Because ultimately, that is the main barometer on whether or not your communication strategy was effective. So if, for example, the outcome is you want to increase funding for a particular health program, and you present evidence on the effectiveness of the interventions, on the unmet need, for example, and why they should increase budgets. If that budget is not increased, then maybe in some ways you are effective. It gets the topic gets to be addressed or discussed in the agenda, but ultimately it's not also effective because you don't meet your outcome. So I would start there. Start with having a clear outcome for your communication strategy, and then you design your M&E framework and your M&E plan from there. I think those are the questions. I'm not sure if I missed any.
Yeah. I think that you covered it. You covered them well. The next set of questions, no, for the first lecture, looks into specific audiences. No, one question was, how do you make your research findings be visible and become local ordinances or resolutions in the case of a local government unit?
Mm-hmm.
How do you communicate these research findings to GIDA, no, or geographically isolated and disadvantaged areas, with all the social, cultural, and political issues related to a particular area? And how do you bring this to schools and homes, no, as one particular venue, no, for these particular studies?
Mm-hmm.
And then some comments, no, on the post-truth discussion that you had. The issue of post-truth versus scientific evidence, no, and how one deals with that in doing research communication.
Mm-hmm.
And the other one is when you speak out, it can hurt some people. It can hurt some institutions, or it can hurt some people in decision makers. No.
Mm.
So again, that was raised as an issue. similar to the other one on post-truth versus scientific.
Right.
On those later. After this set of questions, we'll go to the questions or comments on the policy brief. Thank you, Jason.
Thank you very much, Doc Dennis. Regarding the local translating research into local ordinances, reaching geographically isolated areas and reaching schools and homes. Actually, the first answer to that is more research. Part of the communication process is a stage where we refer to as formative research. So in this part of the communication planning process, we try to understand what are the different channels that are available to the audiences that we want to reach. What are their pre-existing levels of awareness, knowledge, attitudes, and practices? And sometimes we even go as far as pre-testing messaging or materials interventions to see whether or not these audiences would respond to these messages positively. So that's, I think, if that information is not available, then, and if there is time and resources available to gather that information, I would start there. You can make some assumptions, obviously. For example, for GIDA areas, you are looking at very interpersonal and community channels as opposed to mass media or digital or social media. So one way of doing that is to empower people who actually interface with these communities with materials that they can bring and that they can show or that they can discuss with these communities. And also training their own capacity as community mobilizers to talk about a particular issue. So one practical thing we like to do with these kinds of grassroots campaigns is to come up with a script, as simple as that, a script that a community mobilizer can memorize, translate into his or her own words, with some commonly asked questions, FAQs, questions and answers that they can use as a basis for dialoguing with these communities. I don't think, certainly it's difficult to reach these communities, but it's not impossible. It's all about finding what are the channels that are available to them and what channels will they respond to. For schools and homes, mass media is a channel that we often use because of its reach. But I think one effective way of reaching schools and homes is just trying to understand what is it exactly that you want to communicate in these settings, right? If it's about behavior, then I think part of the formative part of the research is to understand what are the dynamics between the different members of schools and communities. So a common strategy that we use is to empower parents and teachers, for example, because their natural role is to model good behavior, but also to help students and young children, young people to practice healthy behaviors as well. So these are just different ways of reaching these different settings, but it always goes back to what is the outcome that you want. And once you're very clear with the outcome that you want, whether it's practicing a new behavior, passing a new ordinance or a new policy, increasing funding or budgets for one thing or the other, then that should already guide you in the succeeding steps. The formative research you need to take, the channels that you will use, the materials that you will develop, and the messages that you will put out there. On the issue about post-truth, I think this is a very, very, what do you call it? A very critical moment now in humanity, actually, if you want to reflect on it that way, because because of the COVID-19 pandemic, I think we are seeing the direct effects of certain forms of leadership that does not, let's just say, that is more populist and does not really respect or even adhere to scientific evidence. And I think we can do an entire webinar about why and how we arrived at this moment in time, and that's not really the subject here. But one thing I would say is that there are a lot of, as a result of this pandemic, we now have a lot of good role models, I think, that we can look up to for people who are not afraid to speak truth to power, who are effective in communicating science in a way that is inclusive and that is motivating and that addresses not just the facts but also the emotion, but in not in a manipulative way, but in a very truthful way. And a good example for is Dr. Anthony Fauci. I think many of us by now know his name. Certainly, for those of us who studied medicine, he's one of the authors of the textbooks of internal medicine that we all had to read during medical school. So he's a familiar name. But because of the media attention drawn to his work now, and of course the challenges that they're facing in America, I think he is a good example of a science communicator who is not afraid to speak truth to power, who knows the evidence, who knows the facts, and is able to articulate it in a way that his position is very clear. And he is also interesting because he has assumed the position, I think, for over 30 years. So that's through different administrations, whether it's Democrat or Republican. So that's a very good example. And there are other global leaders, I think, that we can look at who are examples of effective public health communication. The Prime Minister of New Zealand is somebody I admire. I think she's very good at the way she communicates about the evidence about COVID, and other leaders, I think, that are very good. I would not want to drop names here in the Philippines because I know it's a very politically sensitive issue. But suffice to say, there are also very excellent science communicators here in our own community.
Okay, thank you, Jason. No, thanks again for those responses. Now, for the policy brief, I'll just list down almost all of the questions were somehow operational or operational issues. So one is, how do we manage policy briefs now that we are in a virtual environment?
Mm-hmm.
And then for policy briefs that are hard copies, how many pages should those be? And there was a question on options and evidence component part in the policy brief, how different it is from I think the last part was recommendations.
Right.
And then there was a question on the role of ethics in research communication.
Mm-hmm.
And would you recommend because a lot of the skills the respondent or what the participants said would be skills that are from copy editors or editors, no? So why not just stop these professionals for some of the needed inputs, no, for research communication?
Right.
And then there was a question on whether for government-funded projects, can they use their logo of the institution for the policy briefs if they are going to give the same policy brief to another government agency or a local government unit. So the other questions were more of suggestions on possibly using also the theory of planned behavior or the healthy literacy model.
Yep.
As a possible option. Those were more of comments. But on the policy brief, I think the questions were more operational, or how they would be able to do a policy brief, and also how do they sort of manage the policy brief once it's out. So back to you.
Okay, thank you very much, Doc Dennis. I think on the nature of the document itself, because yes, we're having to do a lot of things online. I think that actually liberates the policy brief in many ways, because you're no longer constrained to an actual paper document. It can be a living document that is more interactive, where you have animation, for example, video excerpts. The graphs, for example, can be animated to show trends over time. So I think it's an exciting time to be developing policy briefs now, because we are having to do it virtually. Certainly, that does require a certain skill set that many of us, my present company included, might not have. So working with multimedia professionals, communication professionals, I think is the way to go. If you can do it yourself, why not? That's never a bad skill to have. The number of pages, that's very relative. I think what you're aiming for is still brevity. So there's, frankly, I have not encountered any specific standards or rule of thumb or about the number of pages. One way I'd like to kind of gauge whether it's already too long is try to imagine how much time it would take to read through your policy brief. If it will take half an hour, then that's obviously that's not a policy brief. So what you want is to communicate your idea in probably 10 minutes, or 10-minute reading material or less, and that should give you some kind of barometer on whether you're writing it too long or too short. Also, the differences between options, evidence, and recommendations. Well, again, there are several different formats offered online, but my understanding is some policy briefs, they offer alternatives. And I forgot to highlight this earlier, so maybe this is a good time to do that. But one way of making the policy brief more palatable or more easier to digest is to scale the recommendation. So, for example, you discuss an issue, let's say depression, and why this is a big problem in the Philippines and what we should be doing. So at the end of it, one way of scaling the recommendations is in terms of time. So what should we do in the short term? So these are recommendations on what to do on Monday morning. When you get back to your office, convene a technical working group, try to determine the different what you call this interventions that are available, etc., etc. And then you have medium term and long term recommendations. So that's one way of presenting different policy options. So they're not necessarily choosing one from the other, but it can be presented in a stepwise manner. So then it becomes less overwhelming or daunting for the policymaker that, okay, I need to pass a mental health law tomorrow. Obviously, that's not going to happen, but maybe before we get to that, these are things that you can do to prepare for that. Ethics is obviously very important in communication, as it is in any other branch of science. We have to make sure that, first of all, we're not lying. I think we have to be honest. We have to be truthful. So please don't misunderstand when I say that we need to frame the argument or that we need to use storytelling, that we are misleading. No, framing refers to presenting certain parts or certain angles of the evidence or the argument in a way that is that will appeal most to your target audience. So you're obviously not misrepresenting or misleading. That's very important, and we should always adhere to ethical principles in communication, and there are standards available. In terms of, is it just, why don't we just give it to somebody else? Why don't we just give it to a creative professional, a professional writer, designer, etc.? You can certainly do that. And I think in some instances, it is helpful to collaborate with communication professionals. But I think it is part of our basic skill set as members of a scientific community to communicate well. And if at the very basic level, we have to be able to speak and to write well, to communicate our ideas properly. More technical skills such as graphic design, art direction, photography, video production, maybe that we can work with multimedia people. But even then, my experience has been these other colleagues working in the creative industry, they will ask us, they will rely on us to at the very least determine what the key message of this piece of communication is. So it is important for us to still develop those basic skills: writing well, speaking well, communicating well. On the use of logos, usually this is there are specific guidelines regarding the use of logos. So my advice would be first to consult what are the guidelines of that particular institution. And it refers to two things, usually. One, how the logo is presented. So guidelines would determine whether or not a logo can be superimposed over a certain background, or it should only be presented over a white background. So they can be very, very specific. But then on the other hand, they also there are also some guidelines on appropriate use, on whether or not these logos can be put in certain products, and what would be the circumstances behind whether they would grant permission. So you would want to consult those guidelines. If there are no guidelines available, then you can just ask permission from the head of office or refer to other guidelines from other offices on what would be the appropriate use. And then, yes, I thank you. No, I am a believer in those two models, planned behavior and health literacy. I think those are two very relevant perspectives, especially when it comes to communication. At the end of the day, we want people to be empowered to make healthy decisions, and that also involves being able to pull up evidence, to appreciate the evidence, to assess the evidence, and ultimately to make decisions based on the evidence that is presented to them. So thank you very much for highlighting that. I think those are very relevant concepts.
Thank you again, Dr. Ligot, for your responses to the questions from our participants. We still have some questions, but we don't have enough time to accommodate them. So we'll probably send them over, for you to see and probably respond to them in some other venue, or probably on Friday we'll have that time.
Sure.
So thank you very much for the inputs, and thank you for the videos, for the video that you shared with us. And that sort of wraps up the second day, for this workshop and webinar and virtual workshop with Dr. Harvy Liwanag and Dr. Jason Ligot. Thank you, Jason.
Thank you, Doc Dennis, and thank you, everyone.
Thank you. At this point, I'd like to give the floor to Dr. Harvy Liwanag for his instructions to our workshop participants. Harvy, over to you.
Thank you, Doc Dennis. I will not be speaking long, but just to inform our participants that our virtual workshop participants will be preparing their policy briefs as groups, and they will also be presenting on Friday to our panel of experts. And so, to our virtual workshop participants, I think you've been informed that the guidelines for the group work is now uploaded in our Google Drive, so please refer to that. And for our webinar participants, maybe invite you again to join us on Friday, so you could hear about the research projects of our virtual workshop participants and how and what sorts of policies they can recommend out of their research projects. Thank you, and back to you, Doc Dennis.
Thank you, Harvy, Dr. Liwanag. Just an important note before we finally end this webinar. A post-webinar notification will be sent after each session. A webinar code for today is pinned on the chat box. Now you see it on the yellow sticky note on your screen, and will also be part of the post-webinar notification containing the link to the evaluation form. Kindly paste the webinar code, which is on your screen, So copy all capitals. Number 1, DOST, that's first, DOST -PCHRD workshop, all caps, _ day 2. When asked for the webinar code. In this event, we have two sets of attendees, as explained by Dr. Liwanag: the general audience and the workshop participants, who are given readings and assignments. Regarding the certificates of attendance will be given to individuals who will be able to attend all 3 webinar sessions. And upon submission of the accomplished evaluation form to be forwarded via email after the webinar on July 17. Certificates of participation will be given only to virtual workshop participants upon passing the quiz to be forwarded via email after the session on July 17. So a lot of our participants are posting it in our webinar chat box. So you have to wait for your post-webinar notification in your email, and that will lead you to the evaluation form, and you will need the webinar code in accessing the evaluation form. And after filling out the evaluation form, that's the time you get your certificate of attendance. And for the workshop participants, they have to fulfill first other requirements for them to get their certificates of participation. So with that, we'd like to thank everyone for participating in this webinar slash a virtual workshop, hosted by the Philippine Council for Health Research and Development of the Department of Science and Technology and the eTURO team of the Ateneo de Manila University Institute of Philippine Culture. You see on your screen, any administrative questions can be directed to the email addresses at PCHRD. And this has been a wonderful afternoon sharing with us their inputs, Dr. Harvy Liwanag and Dr. Jason Ligot, on topics relating to introduction to evidence-informed policymaking for health. This is Dr. Dennis Batangan of Ateneo IPC. Magandang hapon po sa ating lahat, and have a good evening, everyone.